I'll give you a couple of examples where we, in the hospital, we love fentanyl. I've done a lot of ICU time, a lot of time in the ER. So let's say you come in and you just got in a car crash, right? And so I got to put you down, whatever it is. I am gonna put you down. Now I need the neurosurgeon to take a look at you, right? I'm gonna use fentanyl as the neurosurgeon is driving in because you got this big swelling in your head. Why do I want to do that? The neurosurgeon would like to do a physical exam on you to check some reflexes, right? I'm not going to use my morphine. I'm going to use my fentanyl. Why? Fast on, fast off. Fentanyl is extremely addictive, and you can build addiction rapidly, but it's a crappy high.
Sometimes I make mistakes in my life. Life goes on and on and on and on and on. Hey, I got wisdom from my papa. He ain't have a lot of money, but he taught me how to keep the perfect posture. So folding under pressure, that ain't something that I'm about to. Crabs in the barrel, I'm just trying to be a lobster. I hit my cousin, told him to call. It's been 12 years and I ain't heard from him at all. Had a little fallout over some money. Damn, ain't it funny how the smartest people be beefing like they some dummies? But I hope you doing swell now. Hope your family well now.
Welcome to Primary Purpose with Pej. I'm your host. Today we sit down with a man whose life's work has changed tens of thousands of lives quietly, humbly, and long before addiction medicine became a respected field. Dr. Faried Banihamd, known as Dr. B, began his career as an academic emergency medicine physician teaching, researching, and training the next generation of doctors at UCLA Kern Medical Center and later at UC Irvine. On paper, he had a career many dream of, but his true calling pulled him somewhere far more difficult, far more controversial, and far more meaningful. He walked away from academic medicine to step directly into the world of addiction, into methadone clinics, detoxes, outpatient programs, and some of the most complex and undeserved cases imaginable. Long before benzo tapers and polypharmacy management were common practice, he was mastering them. Patients call him a magician, not because he performs miracles, but because he listens, he observes, and he knows how to treat people who have been dismissed elsewhere. Over the course of his career, he has cared for more than 80,000 patients, an entire stadium's worth of human lives, helping them navigate addiction, medication, mismanagement, and the long road back to hope. Today, he runs Zephyr Medical Group in Orange County, where he continues to serve the underserved, consult on complex cases, work with legal teams, train institutions, and design private detox and rehabilitation for patients around the world. In 2017, he was named one of Orange County's top influencers, a recognition of the impact he's had not just in medicine, but the lives of individuals and families across the globe. Guiding his practice in a quote he lives by from St. Augustine, "Hope has two beautiful daughters. Their names are anger and courage. Anger at the way things are, and courage to see that they do not remain as they are." Here we go. Welcome to the show.
Thanks. It's good to be back. It's been a while. We've been trying to do this for a while, right?
Yeah, I mean, we did one before when it wasn't this type of setup.
Yeah.
This is the actual, official, Primary Purpose with Pej. And it's good to have. So this is Dr. Faried Banihamd.
Yep, Faried Banihamd.
Known as
Dr. B.
Dr. B.
Yeah.
And I always like to get professionals on here, especially the ones that are addictionologists or really have a lot of knowledge base, and you are a wealth of knowledge with the amount of stuff. I mean, really, I watch a lot of your videos on TikTok, and we'll get into all that. But tell us about yourself a little bit. Why did you even get into this field? Where were you born, raised, all that stuff? And then let's get into the nitty gritty, because we've got a lot of stuff to talk about. Really, very important stuff.
Okay, I'll try and be brief. Cut me off, okay? And we talked about this.
Let's just go like this.
Yeah, we'll talk about this earlier. I was born in Iran. I immigrated to the United States, I think 7 years old.
Okay.
Right? So I've been here forever. Having California, yeah, the whole time California. I've traveled extensively across the U.S., but coming all the way up to, my background is actually a lot of people don't know, but my real background and original passion wasn't medicine. I was more involved and spent years in linguistics, philosophy of language, some areas of mathematics, things like that. Anyway, medicine, and by training and most of my career, I've been an academic emergency medicine physician.
Were you like a typical Persian that your family really wanted you to study medicine or engineering, and that's just why you were so driven to go into medicine, if that was your original, what you really liked before linguistics?
This itself is interesting. I had zero interest in medicine, and my family comes from a really deep, old, culturally, in that Iranian culture, academic background.
Mm-hmm.
Everyone was professors, PhDs, stuff like that. Some professionals, and nobody really in medicine at all. Mostly university academics, well published, well respected.
Interesting, because I come from a family that my father was a microbiologist, a virologist, and a food scientist, and we have a lot of family members that were in medicine, and the hope was for me to go into the medical field, but instead of studying medicine, I started using the medicine.
That's interesting. Did you have an interest in going into medicine?
Well, my mom used to take me to her anatomy classes in Utah because we migrated here probably around the same time as you. I was 5 when I came here. I was born in Germany, but we went to Utah, and she'd take me to her anatomy classes with the hopes of me gaining an interest in learning the human anatomy and biology and all that. None of that was all out the window by the time
Really?
I was cool. Yeah.
Oh, I did not.
Because I was a full-blown addict by the time I was 12.
Yeah. I mean, but I didn't know that background. That's interesting.
Yeah.
I didn't really have an interest in medicine. I actually literally made the decision to pursue medicine in one day.
Mm-hmm.
I actually went out. I was partying. I was pretty rambunctious young man.
Yeah.
Some people would. I've never actually said this in the online world, but you wanted to know me.
Too late.
I had people tell in my late teens, early 20s, say, "It's too bad you're writing my essays for me, helping me with my exams, but you'll probably be dead by 30." Because I like partying. I wasn't a drug addict. I didn't do drugs, but I did party pretty hard and just did what I wanted to. But I sat down one day and I was like, okay, what do I really want to do? What I really wanted to do was stay in academics, but I didn't have the courage, because the kind of academics that I aspired to, and being an academic snob, I only would accept if I got a full 10-year professorship at somewhere like Harvard for life, and I made a major contribution. And I'm sitting here thinking, how hard is that? And number two, I also always knew that I have no respect for my finances and how I live. So I needed a steady income, something that's structured and easy. I was like, okay, so forget academics, because you're going to be, even though it's wonderful and I'd love teaching at a junior college. In fact, that would be my dream job today. Yeah. I didn't want to do that at that age. So I'm like, what do you want to do? And I decided I want to go defend death penalty cases in Texas. So I'm going to go to a big law school and then get into criminal law and defend those guys that are being put down with the IQ isn't there and whatever. I felt that was unjust. Then I thought about it some more, and I was like, okay, you're probably going to still be dead by 40 if you go that route, because you're going to fight a system that it's a losing battle, and you're going to smoke, drink, or some judge, DA, or cop is going to shoot you. I was like, well, maybe I shouldn't do that. Believe it or not, this was my...
That was your interest.
This was my calculus that in one night, I sat down and I actually had a drink, if I can say that, for, people think... I don't drink now, but... Yeah. So I was like, well, what is it that I can do that even if I'm an asshole or a jerk, but I go, and I was obsessed with my moral calculus. Yeah. Coming from the background of theology, linguistics, philosophy, I was extremely obsessed with my moral outcome in this world. And I was like, what can I do that no matter what I do every day, it's going to do some good? I was like, okay, I'll go to med school. And that's how that decision was made, believe it or not.
Wow. And where did you go to med school?
I went to UC Irvine. I ended up, I really stayed in academic medicine. I ended up at UCLA Kern. I was an assistant clinical professor. For a while, I was director of research. I made a migration to UC Irvine, again, assistant clinical professor. And during that whole time, there was a lot of things going on. I was becoming disillusioned by academic medicine because it was turning like corporate private medicine. And, I spent 15 years in scrubs living in a hospital, and now there's all these residency time rules that they can't be there 8 hours. I used to live in a hospital, and I was like, if you're going to learn disease, you need to live here and watch a patient go through everything. And I was like, I felt residents weren't, the new generation of doctors didn't care. And, I felt medicine for me from day one was no different than it is for a guy going to become a priest. I really believe that. And I felt like you should give me my income so I can focus on that. And so I was like, well, why am I in this setting when they're asking me to go to meetings and play with Excel sheets? I just want to be at bedside and teaching. I also had this thing always for guys that came in on heroin, had reversals, all that stuff. I didn't like the way they were treated. And being narcissistic in my clinical prowess and having a big ego, I started looking into this, and I was like,
this as in what?
What was happening
Addiction?
in substance abuse treatment and addiction medicine. I was like, I can do this better. These guys are insane. What are they doing?
Yeah.
And I just walked off. I still have my professorship as a volunteer clinical professor at UC Irvine, affiliated with the department. I'll probably do a course in the next couple of years in the undergrad, because that's what I want. I'm tired of training. But I walked away and started doing addiction medicine, and the rest is history.
So you're not a psychiatrist.
I am not a psychiatrist.
Addictionologist?
Yeah, I'm an addictionologist, and my background and initial training was emergency medicine. And that's where I come from. And it served me well because I know the medicine I know so well. All I did was translate everything I do to the rules of addiction medicine.
Gotcha. Okay, so then let's walk into this. So when did you actually, what years was it that you got into that? 90s?
People think that. Do you want to know how long I've actually been practicing addiction medicine? If I was going to push it really far back, 2014, 15.
Interesting, because when I listen to you, you sound like an expert in the field.
People think I've been doing it for 30 years. And I'm like, dude, hey, do I look that old? But
I think we're around the same age.
Yeah, but I noticed they were putting. I've actually seen over 100,000 patients. Most of those were in hospital, emergency medicine, critical care. I've seen over 4,000 kids.
Okay,
addiction medicine, 10 years, right? But when I get into something, I immerse myself in the theoretical foundations of that, and I become obsessive, and I make sure I understand it inside out. Plus my area that I was really in, emergency medicine, toxicology is a field out of that. And inside of toxicology is heroin, right? Or any substance of abuse. And I always focused on that. And I particularly focused on addicts and how they were being treated when they came in, how to do reversals. I mean, I could make that Narcan dance in the trauma bay. The room is a trauma bay.
Yeah.
So I knew I knew quite a bit, but I really immersed myself.
Okay. Well, let's get into talking about the different substances that we actually discussed before that we see a lot of addiction that's going on currently, but also what it was years ago and what it's become now. And then we'll talk about medication-assisted treatment, MAT, that we've got different stances, but we've always kind of met at the crossroads. I like to keep an open mind to the harm reduction community. I've been criticized. I've been known to be controversial when it comes to speaking my mind about it. Often when I do get criticized, a lot of the people that will criticize me will say, well, there's peer reviews, there's science peer reviews, there's evidence-based, and from what I see, based off of what I see on the front lines, evidence-based through my own vision, and the recovery that can come out of it, I think to myself quite often, why should people be kept stuck? Example, methadone clinics. Like, why is that person really living, or are they just going to the clinic every day to take something to stay off of something? So we'll get into that in a sec. But I did want to discuss today ketamine, the abuse of it, also the proper use of it, how it's it's become more popular, obviously probably in the last 5, 6, 7, maybe even more, 8, 9 years for depression. And I wanted to talk about Xylazine, and then obviously, fentanyl, this fentanyl craze, and how it's just grown and grown and grown and become, it's not going away. I mean, I'm sure you're dealing with this a lot. So let's talk. Let's talk about ketamine first. What do you see? What I've noticed, and I told you this the other day when we were talking on the phone. It's like we used ketamine in the 90s. Just
I was gonna go. Yeah,
in the 90s, we it was a club drug. We would go into K-holes. Often we would find it in South America in certain places, and then bring it up here and figure out how to use it. And it was in a powder form. When we would do it, we would do it through our nostrils. And personally, I didn't really like it. I liked some hallucinogens. I liked a lot of stimulants. I loved ecstasy. But when we do ketamine, it would take me into other realms of my mind where I was like, I don't know that I really like that, but I'll do it again because I'm an addict, right? But now what I'm seeing is there are millennials between the ages of 35 and I'd say 42, 43 that are straight up banging lines of ketamine like we were doing cocaine in the 80s and 90s. And it's become like, I've literally tried to help a lot of them. Some want the help, some receive the help from me as an interventionist to try to put them into treatment and get the help that they need. And some just don't want to get help. They want to, they're not in a K-hole. They're using it functioning in everyday life. What is that?
I have a question for you. Can I?
Yeah. Any question?
The guys that you're seeing, these millennials, is ketamine their primary substance of abuse, or do they are they? And I hate using the word addicts, but we'll do it for ease, right?
Whatever you want to call it. Yeah.
But do they have general addiction to other things? Whether it's
they've had past addictions to other things, yes. But now it's gone into that direction. Same goes with nitrous oxide. Yeah. I know some people that used to be heavy cocaine users or used to be heavy crack users or meth users, but now they've resorted to just doing nitrous. It's a cheap thrill. It's short-lived, but they do a lot of it from a canister, which they're buying from these smoke shops.
I see. The nitrous oxide is interesting. You're saying seeing older people do that?
No. Well, there's people that, some. Yeah. Actually, yes. Yeah. Some that are in their 40s and 50s.
Well, that's one of. In fact, I've been meaning to do.
It's very psychological.
Yeah, and I've been meaning to do a series on that because it's in and out of your system, and no one tests for it. And a lot of the kids that were in rehabs were doing that. No one would catch on. All of a sudden, they're just out cold, and they think they took Xanax. And maybe we'll do that another time. But sure, I think ketamine. Sometimes it's a good approach to understand it historically. This stuff is a cousin of PCP structurally, right? Okay. And in the 50s or 60s, they were looking for a sort of an anesthetic. And the issue with ketamine, let's put PCP aside, was that you have an emergence reaction. It's technically what's called a dissociative anesthetic. And by that disassociation, you can deal with pain and memory, because anesthesia, you want people to forget all this stuff. They didn't like it so much because there's a resurgence reaction when people wake up, especially adults, right?
Yeah.
And let me actually take that back. This was the case with PCP, and it moved off the table really bad. But it ended up also happening with ketamine. Okay, so you go through, and you mentioned in the 90s, there was also a substance of abuse in the 70s, right? But ketamine, I've used often over the years it was always great for children because it's a fast on, fast off, and it works. Let's say you're 4 or 5 years old and you got this big gash in your leg.
Yeah.
I like ketamine because it takes them out in that K-hole, and they're just like, and the airway is pretty much protected. You do your thing, they wake up, they don't have that waking up reaction, and where they go kind of ballistic, and it's very uncomfortable for an adult when they do that, and they can get violent. But it's always been a substance of abuse. The next indication, medical indication for ketamine, came after we dealt with the opiate crisis, and doctors are giving out too much pain pills. Everyone was getting in trouble. It started to take its place, especially in emergency medicine, as medication for pain. And it is used that way, right? So you don't have to give them opiates. You use it, and there's dosages and indications. Okay, so when that happened, I was, and this was in late 2000s, 2008, 9, 10, whatever. And it's very common in the ER now. But once it did that, I was like, oh, this is going to become a substance of abuse now, right? Because I know the history of ketamine, and sure enough, it has. Now, moving on, the next thing that happened, ketamine, and became an indication for it became treatment-resistant depression. Now, this is where we take this kind of thing. We got to be careful. Okay, great. Now, all molecules, many, that in the scope that we're discussing, they have mirror images, right? And so it's only one of the, so you take my hand like this, you put it in front of the mirror, you got this. These two actually don't fit on each other. It's a three-dimensional molecule. So each one might be active, the other one is not so active. One of those mirror images is the one that a psychiatrist can use intranasally for certain treatment-resistant depressions at a certain dose for a certain amount of time. Done. At the same time as this research is going on for ketamine, most things that everyone uses and sees are ketamine clinics. These are what I call boutique clinics. And if someone's looking into ketamine for therapeutic purposes, they need to understand this. I can go open one right now and make a boatload of money. And you can tell a boutique clinic when you look at their website, and it's like anxiety, depression, PTSD, withdrawal from Valium, withdrawal from opium. Those clinics use IV ketamine, maybe
infused.
It's not it might be the racemic, which means both mirror images at different dosages, right? There's no evidence for any of that, and it's not FDA approved. But I say that, and I want people to really understand this. I'm not saying ketamine may not have therapeutic purposes for these other things. It's the same discussion with kratom. It absolutely is being researched and can grow into that. But at the moment, the clinics that you see, 90% of them are boutique clinics. Okay. And then there's the psychiatrist. And in that space, that popularity and presence of ketamine has grown even more than when the ER doctors started using it for pain, and pain clinics do too. So obviously it's going to get out there more for abuse and misuse. And you'll see guys like, who's the actor that passed away from it?
It was Matt Perry.
Okay, Matt Perry. His issue was, you have a celebrity client, and the doses that he was getting to take home, it's just too much. And this guy was, was an addict. And that's what really took him down. I actually read his whole autopsy report, what was in his autopsy. I also saw the medication whole regimen that he had at home. First thing I would have done is what I call, this is a coin I throw, medication hygiene with this patient. All right, let's take a look at how you deal with medication. But somebody was giving him too much ketamine. That's what killed him. Okay. So that is what the history of ketamine is coming up to now. And it is only natural within our social milieu that you're going to start to get abuse, misuse, and addiction. And you're absolutely right. And it seems like it's even grown more than I thought.
More than ever. I have some questions too, because I get these questions from people and I even make videos about it. Can someone overdose on meth?
Not technically.
Not technically. Can they have cardiac arrest?
Yeah. So,
Strokes,
yeah. So,
aneurysms?
sure. The overdose on meth would be stroke. It would be a catastrophic cardiovascular cerebral accident. And it's even more than that. When I say vascular, for example, you could get a stroke to your stomach. If you get a stroke to your stomach, blood is not getting to your gastrointestinal tract. If blood's not getting to your gastrointestinal tract, that part of the gastrointestinal tract dies. If it dies and you wait long enough, and that's not very long, could be 12 hours, you will become septic and you will die. So those are the kind of events that happens with methamphetamine.
Thanks for that. Okay.
Yeah.
Now, here's another question I have. This happened when I was working in rehabs, running groups, and just knowing the history of ADHD, and a lot of doctors think there's a major necessity for ADHD medications for kids when they're acting a certain way, and they need to. Does it calm kids down? Is when they give it to kids, correct?
Yes, that's what they're.
Okay.
Yeah.
But as opposed to like a student that's in college takes it to be more assertive and concentrate better in, let's say, a studious setting, totally different than calming them down, correct?
Yeah. I mean, it can be both. Calming him down, there's attention deficit, there's attention hyperactivity deficit, and all of those can present at different points in life. So you can, and a person often knows it, but So
where I'm going with this is when I was working in rehabs, so one time I asked in a group setting where we had fentanyl addicts, heroin addicts, meth addicts. These were all people that were addicted to various different types of substances in their later life, in their young adulthood. But I asked, how many of you have ADHD? A lot of hands went up. I said, how many of you were prescribed Adderall or Ritalin when you were younger? A lot of hands went up. And it made me wonder, can perhaps if doctors are over-prescribing or just prescribing for good intention for their patients, can this make someone develop an addiction or a dependency to a substance, which later in life can transfer into other substances because they've felt an effect as a result of using a substance to help their psyche, per se?
Yeah. So let me start off by saying this. Your question is loaded, not in a bad way. Why it's loaded is in that question, you asked me something that opens a can of worms. It needs to be deconstructed. And we could spend about and in fact, after I finish my benzo series on my thing, and I get into stimulants, and I avoid getting into ADHD for different reasons. But there's so many questions in there, and each one could be hours of discussion. And I want to give you some answer that you can walk away with, the viewers can walk away with.
The reason I have strong opinions about it is because I know that a lot of people that end up, even in later life, like when they're in young adulthood, that are continuing to be on ADHD medications, often will start to take more than prescribed and then take it to the next level and just resort to straight street meth.
Yeah.
Because they're used to the stimulant helping them to a certain extent, but they want something better. And at this point, they might just have straight up addiction and think that this isn't enough.
Let's unpack and try and take some of this and answer. And, I think where you're going in, if we distill it and we can say, hey, Pedge is trying to creep upon the fact that this stuff can actually lead to using other drugs.
Something along those lines.
And that's a fair, legitimate potential question. And I would say if it does, it's because it was mismanaged in the first place. And when
by the doctor or by the patient?
By the doctor, it was it's everybody's. It's not an issue of fault. It's everybody's poor approach to this situation. ADHD, and I don't want to get into this because I don't want people calling me on this medication because I have so much on my plate. I don't want to.
Yeah.
I do treat this.
You do.
And in fact, I have maybe 3 underage patients that the parents really forced me to manage these kids with major behavioral problems. It's different sorts. And immediately within 10 minutes, I said, he needs to be on a stimulant, right? And the minute I put him on the stimulant, life changed. And it goes that way forever. And
Behavior changes?
Everything. If we're talking about school, going out to do meth, committing, what do you call it? Not violence, but when you go destroy something, what's the word I'm looking for?
Vandalism?
Vandalism, vandalizing schools, poor grades, impulsive, promiscuous behavior. Bam. I have another kid that, stayed and locked up in the house. He's actually not a minor. He's now, I think, he's right around there. Hasn't really left the house in a couple of years, right?
Yeah.
With major issues. Bam. He's going to work with his dad. He's now.
So everyone's different.
If a child truly has ADHD as a kid, number one, I recommend this. Medications are poorly managed by the clinical world now. They're misunderstood, misused, and people don't understand that relationship you have to have between you, the patient, and the medication, 3-way going around to effectively manage medication. ADHD is a great thing. So, if someone was put on some medications when they were a kid, then they came off of it and the ADHD is still there. Because I can tell you on the other side of this, if your ADHD growing up is not appropriately treated, whatever that means, you do have a risk of poor outcomes, including substance abuse, poor health outcomes, poor occupational, social outcomes. So there's that other side that's very well documented, and I'm aware of it, right? And, every time I put someone on the dose, it's a life-changing effect.
Okay.
And in fact, it's a potential treatment for stimulant abuse, and this starts to get wound up to ADHD versus meth addiction. You got to do it right. And what in our culture, society, and time at this time, people have forgotten what real medical management is.
So by doing it right, you mean by managing it correctly?
Yeah, I'll give you one example. My patients aren't on 60 milligrams of Adderall, 80 milligrams of Adderall, the ones that are similar. Like you might go into a doctor.
Low dosage. Huh? They're on a lower.
You wouldn't believe, my patient, you go into a doctor, oh, you have a history of substance abuse? Okay, no, the only thing we can do is, I don't know, Vyvanse or something.
Yeah.
My patients are on 5 milligrams of extended release Adderall. The one that's on the biggest dose is on, I think, 10 or 15 milligrams of extended release with 5 milligrams of IR. They manage beautifully. And these are adults. They're younger people. So my answer to you is it can. But the reason it does is it was never appropriately, consistently, chronically managed, and nobody understood what attention disorders really are. They are a disorder of mood and emotion, much more they are of cognitive prowess and ability. And if you can understand that and hit those things in the right way, you would never get in trouble.
That makes sense. Okay.
I hope that answers.
It helps a lot. It's good to know. Strattera is a non-narcotic alternative.
Sure.
Do you support that? Is Strattera a stimulant?
Yeah, I support all medications done the right way. And for me, I and this is the hard thing for me, everything is dependent on what that patient needs and what works for that patient.
Fair.
So, all of it can be, there's very few medications that I am an absolute no about. Now, the most extreme things that I'm no about with my patients, gabapentin and Xanax, okay?
Yeah.
And Soma, and even with those, I have 1 or 2 patients on those closely monitored.
Understandable.
Yeah.
Okay.
Yeah.
Now, fentanyl. Obviously, this has been medically used for decades.
Yeah.
Pain reliever.
Yeah.
Obviously, we saw a lot of traditional heroin addicts that were using heroin in the 60s and the 70s and the 80s, and nobody was abusing fentanyl. It wasn't even out there. It wasn't available. Then I think late 90s, early 2000s, people started getting fentanyl patches and fentanyl lollipops for pain.
Medically, yeah.
For pain.
Yeah.
But somehow people with addiction problems got their hands on the patches and started actually abusing it.
Yeah.
And then, but what we see right now, there's a book called Fentanyl Incorporated. Have you heard about it? Fentanyl Inc.?
Yeah, I have.
The scientists in China were distributing a lot of it, or manufacturing a lot of it.
Familiar with that.
And then it started, you started seeing this fentanyl craze. And I don't think that the fentanyl that's on the streets is equivalent to what's in the medical setting, although it's still
fentanyl.
It is still fentanyl. It still acts as it.
Yeah.
Then we've seen over the years isofentanyl and carfentanyl, and these are higher potency of fentanyl. Is that
some of them? Yeah. So that fentanyl class, it's at least 25. It's endless, but you can have. They can have derivatives of until the cows come home.
Yeah, and typically with heroin, people were either smoking it, snorting it, or shooting it. But you don't see people with fentanyl addiction, they're actually shooting it. They're mostly smoking it.
Yeah. So your first point, fentanyl I've used fentanyl a million times. It's fantastic drug. It's something we've been using. It's potent, much more potent.
Using it for what? Medically for somebody you've been prescribing it?
I used it never. Yeah, that would be the guys that prescribe.
Oh, you're using it in a medical setting?
Yeah, in the hospital. But the guys that prescribe it for home would be oncologists for the most part. Yes. Maybe some pain guys, and they've moved away.
So you were using it before you even got in the addiction field for patients that you were working.
Yeah, I'll tell you. I'll give you a couple of examples where we, in the hospital, we love fentanyl. I've done a lot of ICU time, a lot of time in the ER. So let's say you come in and you just got in a car crash, right? And so I got to put you down, whatever it is. I am gonna put you down. And intubate you, and a CT comes back. So now I need the neurosurgery to take a look at you.
Yeah.
Right. So I'm going to use fentanyl as the neurosurgeon is driving in because you got this big swelling in your head.
Yeah.
Why do I want to do that? The neurosurgeon would like to do a physical exam on you to check some reflexes, right? I'm not going to use my morphine. I'm going to use my fentanyl. Why? Fast on, fast off.
Oh, okay.
Right? You go to get a GI procedure, right?
Mm-hmm.
What do they use? Fentanyl. Fast on, fast off. It's a same-day surgery, right? The general go-to is usually not fentanyl, it's morphine, right? Sometimes you might use fentanyl, but in the ICU, same thing. All right, 2 o'clock, we're going to round on this guy. So you'd write the order for them to do fentanyl that day, because it comes off so fast. Now I can do a clear exam on you, whether I'm checking your reflexes, whether I'm checking your alertness, all that stuff.
Yeah.
So fentanyl, its value in medicine, A, it's short acting. B, let's say I was trying to treat you and you're awake and my morphine isn't doing anything. I'll go switch over to fentanyl. Boom, see if that works. Great drug, We've always used it, and so forth. All right, it's much more potent, right, than morphine. Now, the street thing you're talking about,
Yes.
And I'll even address why they're smoking it. The evolution of that street thing is, you can sort this out by just looking at it as an capitalistic economic pursuit by the manufacturers and drug dealers and cartels, right? Distributors, right? So, I'm a cartel, and let's say I'm in Mexico and growing my own poppies of heroin, right? Everybody's looking for the cheapest way to manufacture whatever they're doing and cut costs, right? And get it to you quickly. It's a lot easier.
Fentanyl's cheaper.
It's cheaper and easier. Bunch of fields versus a lab, right?
Yeah.
And now,
so it's synthetic.
It's synthetic, right? So you can do it in a lab. Now, that lab is not going to have crap for standards, right? So now, it's going to have some issues in its distribution, and it's dangerous because already, this stuff is a lot more potent. So whatever you're making is going to have quite a bit of fentanyl. Now you want to start cutting things down, cutting your dope up, right?
Yeah.
And so, as nowadays, and maybe we'll address this, that stuff has everything in it, because by the time it gets to the street, it's dirt cheap. Now, there's one more thing. Why are people in general more smoking than anything? I think a lot of that there's been kind of a trend and a shift from injection to smoking. It's cleaner, easier, and much easier to hide. And it was sort of the response of the consumers to deal with soft tissue infections, overdose, whatever it is, the needles cleaning. So it was actually I believe that trend towards smoking is a good thing, because it sort of potentially may have contributed to slightly less overdose deaths. But I think it was a consumer response more than anything. And it was a good response, because you don't want to be shoving needles in your veins. I think that's why fentanyl went that way. On the other hand, I actually have a piece on this, and I talk about this, and fentanyl is actually a crappy high. It
just sedates you.
Yeah, I challenge any addict, and I'll sit down, and maybe they weren't thinking of it. Number one, nowadays on the street, you can't get good heroin anymore.
There's really no heroin there.
There is no heroin.
There are some people that know the guy, this is what I hear, that actually still get pure heroin. However, the vast majority of the heroin that's out there is cut with fentanyl.
And I will tell you this, those people that you're talking about, let's say you have unlimited resources, they're even having a hard time getting the real stuff, and they're afraid. And so you're right, it's always been that. So fentanyl is extremely addictive, and you can build addiction rapidly, but it's a crappy high. When you do heroin, from the minute you get the dope in you to the, what I call, that's a marker I've made, the nod-off point. Mm-hmm. The nod-off with heroin, you can almost wake somebody up. And from 0 to 60, in there is a Goldilocks zone, a euphoric spot that people aim for.
That's what they like. Yes, that's
with fentanyl, it's not there. It's crappy, right? It passes right through it. So if you got an addict and talk to them, they would love to be able to do heroin, and they've just forgotten it. The fentanyl is potent as hell, right? So addiction rapidly builds, and they're dosing 5, 6, 7, 8, 9, 10, 15 times a day, and that makes addiction even worse. And so it's become much harder, and I don't want to go into this until you're ready, to get them off of this stuff versus what used to be, and it's messy.
Well, I'm going to bring you on here a lot more so we can get deeper in those types of conversations. Today we're covering a few different substances. Sure. Tranq, Tranq, better known as xylazine, is what it is.
Yeah.
This is also a tranquilizer, right?
Yeah.
But it has fentanyl in it. And I told you the last time that we made that video that I had, during that time, it was just starting to hit the streets of LA. Right now, it's everywhere.
It is.
And there's a lot of people addicted to it. I want, if you could give us a very simplified reason of why they would mix fentanyl into a tranquilizer. That's one.
Yeah.
And then,
I love you asked that.
yeah. And also, obviously it affects parts of the skin. And why does that happen?
Yeah.
Because it's not traditional, like Flocka that used to be in Florida where their limbs seem to fall off. That's not the reason.
Different, yeah.
That's different, correct? So just a two-part question, if you could answer.
Yes, the first part actually is connected to what I was just discussing.
Okay.
The reason you're having to have the kind of dilutant like tranq in fentanyl nowadays, and the reason what they're aiming for is this. Fentanyl is a crappy high.
Yes.
And when you add something like this, it really gets somebody a little bit closer to that Goldilocks zone, that traditional, whether you're smoking opium, doing heroin, even doing morphine, maybe, I don't know, gets. So I think they can get away with, there's two parts of it. One is actually you get to cut up the dope some more. And the second part of it, I think, is the market, naturally or otherwise, demands a better product, because fentanyl is not a good product for getting high. And I think tranq finds its way into that market because the dope is just rugged, dirty, and nightmarish for the user nowadays, right? And I believe tranq is one of those things. And if you look at some of the crap you find in the dope nowadays anyway, you can see there are all some sort of a sedative of some. They're trying to mix it where not only are they saving money, but it gives a better high. And I feel that is the space that tranq ended up occupying. It is an animal tranquilizer. It's an alpha-2 receptor, and so it gives you that sedation. As far as the soft tissue, I don't know if there was any recent. I haven't looked in a few months. I did some videos on tranq, which are really informative. I don't know if people have really sorted out exactly why tranq is the one. Maybe it's there in the literature now. It wasn't a few months ago. There's theories about the fact since it hits alpha-2, it vasoconstricts. They already have horrendous, crappy circulation. There's diabetes. There's, all kinds of poor stuff that is poor circulation. And maybe it leads quicker to an abscess-like thing that turns into necrosis. And again, I got to look again to see if there's anything update, but we also have to remember that population is already not taking care of themselves, has poor hygiene, and there might have been an abscess. And if it is the vasoconstriction, maybe it is, maybe it's not. It's speeding up that basically necrotic processes that present themselves, occur, and move forward. Don't have 100% answer for you on that.
Okay.
I will look to see if there's anything new. I don't think there is, and we don't really know why yet. And I could be wrong on that. I don't think I am.
Okay. Drug-induced psychosis.
Yeah.
A lot of people associate it mostly to methamphetamine use. However, we are seeing a lot of THC, especially the concentrate. Major. Can you give us a simplified breakdown of psychosis and why it happens to some as opposed to some others it doesn't? I mean, I myself, personal experience is that sometimes people have a predisposition. Sometimes they've been up too long. They're dehydrated. They're malnourished. They haven't slept or sleep deprived.
All of those cause psychosis, yeah.
For sure.
Yeah. Or can cause psychosis.
What other substances can cause psychosis, first of all, that you know of?
Yeah.
Can alcohol cause psychosis?
Not as sure. And that's like serious alcohol abuse. And it's going to...
It's more hallucinations, correct?
Well, hallucinations are, technically psychotic disorder is hallucinations and also, fixed false beliefs, right?
Okay.
That is psychosis, and the hallmark of psychotic disorders is schizophrenia, right? Yeah. And it is a spectrum. So depending on, how much alcohol is being used and what the person's circumstance, he hasn't slept, he's been drinking for days, sure, it can. But in general, you don't see the triggering of psychosis that remains in the same way you do with meth. I think something like 40% of methamphetamine users, if they've been using it long enough, will start to experience psychosis.
Okay. So because what I've seen with some people that do get psychosis, if they've come to a point where they've decided to stop using the substance or substances and they want to be on the path of sobriety, I've seen lingering psychosis. Mm-hmm. I've seen psychosis that was only happening to some while they're on the substance. Sometimes I've seen people, I get a lot of messages from a lot of different people, been off of meth for 7 months, 9 months. I still hear voices. I still am in psychosis. And so I often recommend it's time to go see a physician, a doctor, right, that can help you with that. Obviously, Abilify is very helpful, or
any of the antipsychotics, Risperdal, Zyprexa.
And these will minimize or even subside, like take away the voices or the paranoia and things that come with psychosis.
That's it, intention. And, yes, there are people with, again, how long have you used? And it's probably directly related to the sleep deprivation and so forth. But you are right. For some people, they might have been schizophrenic or have psychotic disorder. I do remember one guy who had serious meth issues, and he was going into psychosis. He was in his late 20s at that time. But at that time, I just, ascribed it to methamphetamines. Anyway, got it under control, got him off the meth and so forth, did great. He's my patient again, but it was 3 or 4 years later where he was actually diagnosed with schizophrenia.
Yeah.
And so which came first, what caused what, I don't know, but it looks like it was an inherent schizophrenic situation. The meth just kind of promoted it, got mixed up the thing. And there are some people later in life that, let's say you're 40. Guy calls you and says, "Look, I've been off of meth for 7 months. I'm still hearing voices." You can't call that schizophrenic. It's just auditory hallucinations or psychosis. But I do believe 100% that needs to be treated, right?
For sure.
I don't think things like that are good to leave lingering.
Yeah.
I think the sooner you get the appropriate medication, the better off you are. But I will also add this. For those that deal with methamphetamines and have that issue and that problem, the literature is pretty clear on this going back a long time. The quicker we can get them engaged in, the more active their mind is and engaged in normal life, it helps avoid psychosis and get off meth. But even afterwards, it will help quite a bit. That behavioral modification and engagement in therapeutic is very important for that drug in this situation. And those that have been off for 7 months, they should see a doctor and evaluate and I never say anything 100%, but because that's just wrong. Human beings are not airplanes, so it's not like pull this every time. So yes, they need to really consider an antipsychotic.
Right. We've got, and it's interesting you talked about inherently. We've got at some of my recovery homes a couple of guys. There's one guy that was intravenously shooting methamphetamine for a number of years, all throughout his 20s and 30s. He does. As far as hereditarily in his family, he's got some, I think it's schizophrenia, and obviously he got meth-induced psychosis later because he was shooting this stuff for such a long time. I've known him for years. He's been in our house for quite some time. So he still daily walks in the backyard in a big circle, and sometimes I'll hear him out there. There's been times where he's having conversations, and I'll say, "What are you doing?" He says, I'm just talking to the voices. Well, what are they talking about? Bitcoin, because he's bought Bitcoin in the past. So there's been times where he's managing it. There's been times where he's entertaining it, it seems, the psychosis. And then there's times where he'll start, it's been a long time, where he's literally started punching himself in the face. And I'll call his mom and say, we got to take him to the hospital and put him under observation then they'll manage his medications and get him back to some sort of normalcy. But it seems that he'll have that going on, I think, for the rest of his life.
But it's absolutely very possible and likely. And does he acknowledge it when he's doing that he's talking to something?
That he hears the voices.
Yeah.
He very much acknowledges it.
Okay, yeah.
But they're not evil voices. It used to be that many years ago when I first met him, the voices were telling him bad stuff. At times, he would almost, it was like aliens. He had this electric thing that was some kind of,
sure.
He'd go in the backyard and I'd say, why are you doing that? And he said, because the noise that comes through the electric, some scientific terms he would use, I hear the voices more clearly. And I just thought, okay, well.
Yeah, next time, wherever you are, keep an eye for this. And, part of what I did in my long career is I also managed the psych ER, right? And so I'm, once you do that, I remember when I was a kid, I'd be afraid to walk by a homeless person talking to themselves. But after that, I'm naturally, I just know what's going on with a lot of people on the street.
Yes.
Next time you're out, keep an eye out. It's called responding to internal stimuli. That means you're hearing voices or whatever it is. And every once in a while, you'll see somebody. Now, they might be homeless. They might be a little run down. They might, something's off. But if we're ever together and we see one, I'll point it out to you.
Okay.
You'll see people that are trying to be okay and go about the day, but they're responding to internal stimuli. They're literally hearing voices and trying to deal with that, but not make a big scene about it.
Yeah.
They're acknowledging it and they're aware that it's internal voices, but it's completely destroyed their life. So they're either not under meds or medications are being poorly managed.
Sure.
And it's usually someone that's, on Skid Row.
Yes. Well, sometimes when they're also using, whether it's THC or meth, if they are in psychosis, I think that while they're using it, it's actually making them feel good.
Absolutely.
In those moments.
Yeah.
So they just need more and more of it. But unfortunately, it's also intensifying their psychosis.
It's got to come back. And just to talk about the THC thing, it's absolutely, I said years ago, if you asked me in the 90s and you're like, dude, I'd be like, whatever, man, smoke dope.
Yeah.
In the 90s, you used to say the pot was 100 times stronger than the 70s.
Yeah.
Now, we'll say it's 1,000 times stronger.
And it is.
Yeah. People are ending up in the ER. In fact, I have one tragic case right now. This beautiful, brilliant young man, wonderful mom. And he's on the spectrum, but he's also, he's probably in the genius level IQ, extremely productive and stuff like that. He was, whatever, he was doing the pen stuff, right?
Yes.
And he went into psychosis for a few months.
I've known a few.
Yeah.
I've known a few, and they sometimes they want to know
all the time. Yeah, it's sad.
Very sad. What time is it right now?
It is 4:16.
Okay. Can we have him edit just this part where I said the what time is it part? He'll do that. We're going to talk about MAT right now. Then I'm going to go over the questions, a few questions, and then we're finished. But we got it. This is too much to talk about. We got to do.
Yeah, you got to break it down because I can go deep dive into every. Because I'm like, well, should I be telling him receptors? What's
no. We got to do different part series.
Well, we'll make
sometimes we'll do one just on one subject so that we can go deep. Okay. Which brings us to MAT, medication assisted treatment. Now, I've been criticized a lot. A lot of people think I'm anti-MAT. I know the other day when we were talking to, it seems that you may have been criticized by 12-steppers and you just don't want to have that conversation. And at the end of the day, I am a 12-stepper. I love 12 steps, but I also respect MAT in the sense that, again, I think when it comes to management, if it's responsibly managed, I believe in it. I like it. What I have seen, and I think we can agree on some things that we've talked about before too, is Sublocade. Especially short-term Sublocade, the fact that there's no physical withdrawal for the most part that I've seen with most people, I'm a fan of it. I'm not a fan of methadone. I'm not a fan of methadone clinics. I feel like people become very stuck. I think that some people in methadone that go to methadone clinics are abusing or even their dosage goes up because they're saying they're not, perhaps they're withdrawing. Is that right? Is that why they take up the dose?
Yeah, and I don't disagree. And there's reasons, but yeah,
I've seen people come into treatment at 270 milligrams of methadone, and you have to ask if the clinic's cutting them off at 150, where are they getting the additional milligrams from the plug, from the dealer? A lot of
I don't. It's even worse than that. From the 2000s on, people would do their methadone, walk out on the street, buy a bag of heroin, throw that on. And in the 70s, when benzos came out, addicts are brilliant home chemists. In the 70s, they'd walk out of the methadone clinic and pop a Valium, and that because methadone is an okay high,
Yes.
not really. But yeah, I don't disagree with you. There's reasons for that, but we can get into whatever we want to
Okay.
get into.
More recently, last month, I was working on a case. The guy was 40 years old. He's on Suboxone. He also has a fentanyl addiction and alcohol problem. In our conversation, I wanted to just introduce the idea of maybe one day Sublocade would be a good idea if you wanted to get off completely. Who said I want to get off completely?
Get off of
Of subs, of buprenorphine.
Yeah.
He said, who said I want to get off completely? I go, how long have you been on Suboxone maintenance? 20 years. I go, is this something you want to do for the rest of your life? He said, I wouldn't see it any other way. I said, but you just went to, he had been to treatment a couple of times this year already.
for fentanyl.
Fentanyl.
So
And I said,
was
that-
he stopping this substance?
That's exactly it. So I go, so let me get this straight. You're on Suboxone maintenance, but when you have done fentanyl to go to treatment the last couple of times that brought you to treatment, means you had to stop, obviously. Of course I did. I'm like, so how much harm are you reducing in this process? Like, why would you stop? And he goes, because sometimes I'm still drawn to doing that. Sometimes I still want to do fentanyl. And, that's neither here or there. It's whatever. Like, that's addiction, right? That's a person. For me, this is what I think. I think when people are staying on sub strips or even Subutex and Suboxone, obviously it's been an alternative to methadone, right? And a lot of people, I believe in it. There's a lady I had a heated pissing match discussion with from some clinic over here that was trying to instill fear within a woman that came into I'll bring people into our house that are on Sublocade with a tapered plan with a doctor, hopefully 300 milligrams the first month, 100 the following month, and then nothing. But this lady told her, if you do that, you're going to relapse. And I think that's, excuse my French, absolute bullshit. To say that to someone and not give them a standing chance to be able to work towards becoming 100% abstinent, what is wrong with that? Like, why should someone stay stuck on something to keep them off of something else for the rest of their lives? Tell me about that. What's your opinion? Your thoughts on that? And listen, I know that you all also do your own work when it comes to MAT, so you might have a different outlook, but I'm just wondering.
Yeah. I'm really, I want to answer that, but I was curious on the other guy, right?
Yeah.
He has an alcohol, can I ask about him? He has an alcohol problem also. And then one question I have is, how much Suboxone is he on and who's giving it to him? That's my first question.
I think it was about 16 milligrams a day.
Mm-hmm. The way I would approach that guy, if all of a sudden he just walked in exactly as you described,
Yeah.
I myself, again, I don't care what medication you give, a monkey can write you a prescription for medication.
Yes.
It takes, I hope I don't offend anyone out there. It takes a doctor to know when you need to be on it, when you need to be off of it, how much of it you need to be in conjunction with what other medication. And that's my position on that. So if he came in, I'd really want to understand, what is it that makes you stop, right? I would actually spend time figuring that out to get off the Suboxone and you go use. Mm-hmm. Then I would want to know what other mental health issues are there and what other substance abuse are there. And then I would attempt to, over time, piece by piece decrease the abuse, misuse, and impulsive lifestyle that includes going out and doing fentanyl. And I would expect that to occur. I would have no time expectations of what I do. But what I'm doing in doing that answers one of the questions you asked him for me when you said, well, what's the use? You're going out and using.
Yeah.
Fine.
That's my point.
Okay. And my position would be, if you take and say the year is 100 days, and if he's clean 75 days, that's a lot better than him being potentially very likely clean 10 days. And I'll take the Suboxone anytime, even for the way that he is. Now, I would want to know how often it's happening, because I really get into things and I even micromanage what time you take your subs and try and knock out anxiety, sleep, depression, all of that stuff with it, right? So, if a clinician understands the medication, so that would be my thing with him. Now, with the gal, you said she told that gal you're going to relapse. If a patient came to me, they're on Sublocade and they're saying, I want to get off, and I'm getting on Sublocade because I want to get off.
No, they put her on Sublocade and recommended she stays on it for a long time.
Yeah, and I may do that.
Yeah.
But here's how because I really wait until I get that. Maybe it's what they call the art of medicine, but I know when I have an opinion. But I always qualify like this. If you, let's say you came to me and said, I want to get off, and I knew you really well, and I would first educate you. I would say, well, this is what the data is. This is how the medication was intended.
Yeah.
And here's my position. And let's say you say, I want to get off right now. And this is I would say, I don't agree with that. I don't know how you'll do, but the data is pretty clear. And I actually, for your case, agree that you should stay on it. But I'm going to help you do what you need to do and try and make sure you're successful in the best way I possibly can. And I recommend you let me help you do this so you can be successful, and you need to do X, Y, and Z. With that girl, you said a few things that resonate with me is, this goal of not being on any substance. For me, I make sure, I look at it a very different way. And it's, the substance is neither good or bad. My first job is to give you physical health and safety. My next job is to give you psychological and emotional health, safety, and ability to foster the growth and development in you wherever you are in life. And then my third job is, for each one leading to the other one, is making sure that you grow socially in the way that you see fit. You want to make money, work as a stock, okay, whatever it is. And I start with the physical. And that being the case, I'm not interested in judging whether it's, the heroin is neither good or bad, neither here or there. It's just there.
Yes.
But I know that the metadata tells me that, for most people, the data is very clear that it will get that, would I be rather not taking my blood pressure medication? Heck yeah. Because I'm going to tell you, everything is bad. No matter, Tylenol is bad, right? But everything is a trade-off. Having to go to the store to get that Tylenol sucks. I got to spend money. I got to put something in my mouth and my body.
Yeah.
So everything has a trade-off, and every single small decision I make, even to the point of, should I see you today or not, is a calculus of, will I cause you harm? Will I cause anxiety? And this goes all the way through to where I'm cutting someone open, as in my previous life, or where I'm pushing some medication. Is the risk or benefit potentially at that moment better or worse? And in that patient, I don't know. I certainly wouldn't tell anybody. I don't talk like that, and no professional should talk like that, even if I believe that it should be like, I'm going to give you your options. My thought is it's probably best for you. And then you might turn around and ask me, well, when can I get off? And my ethical, professional, and education is to tell you, I don't know. But the day that it comes, I'll have a good gut feeling that we might be able to try. And if that's not good enough for you, that's fine. I will, if you want to stay with me, I'll try and get you off immediately and we'll work for that. But I want you to also understand that if it doesn't work, there's no shame. Come right back. I don't stick to anything. If we go down this route and you want to get off that benzo in 2 weeks, that's idiotic. You're going to hurt. But no, I'm ready to get off. Yeah. Okay, but understand that I don't care. If you fail and it's not working, come back. We got to fix you and move forward. So although I don't give you a definite answer, I wouldn't describe it the way she does, but I also don't look at it in the way that you're describing because I don't care what the substance is, and I didn't create that nightmare, right? I didn't put that in front of a person. It was a series of events in life and social and environmental interactions with the person and their world and the way they processes that led them to the dope, and here they are now. I have been given this broken situation, and I have to maximize benefit versus harm for that patient at that individual time with the best predictive power I have for the future and honor the patient. And this is actually part of harm reduction is you are an independent, autonomous human being in this world with a free will that is demanded upon me to respect that. So if your position is, I want off, my job, you're going to have to let me educate you. Then I will facilitate you the best I can until you force me to potentially cause you harm or cause me or my practice harm. Then we have to stop. And that's my answer. I hope
that's a good answer, and I respect that. I mean, that's probably the best explained answer I've heard from a medical standpoint.
Yeah.
So, and I mean, that's one of the reasons I respect you too. We haven't really ever had differences of opinions. That's why I want you on here. That's why
I love coming on here. You're amazing.
Why do so many people fall through the cracks of our medical system, and what does it feel like? What does it feel like to watch it happen up close?
It sucks. And to answer to both questions, it sucks. I'm actually almost done with the traditional practice of medicine because it nauseates me. People fall through. We don't have a system. So number one, a system means an organized, programmed approach to reach certain standards for a population. The American healthcare system is not a system. It's a cowboy world of profit, okay, with different incentives and goals. And in the middle of that is marketing, misinformation, bad information. Everybody's driven to survive. And through that, you don't have a system. You have a cowboy system. I'll give you one thing. You know who suffers most in this in our medical system? People think it's the poor. The actual thing is the super poor and the super rich. They both eat crap in the medical system. I have a series of executive clients and a few celebrity clients, and they'll go somewhere and they're excited. Man, I just went to this place and they draw my labs every 3 months and they did this study, that study, and I'm thinking, every one of those studies is garbage, and you had a needle put in you, scarred your vein, you use the system that doesn't need to be system, and you set yourself up mathematically for a potential error in lab interpretation and someone trying to sell you more crap. So that system sucks. What does it feel like for me to watch it? I'm really tired of it, and I'm shifting my focus of my practice once I sort out what to do with a few hundred. I'm probably maybe the only place in the country that is a tertiary practice just addicted to substance abuse, like a cardiac clinic. But I'm trying to figure out how to make sure those people get the care they need. But I at some point, I'm going to shut that down and just work with very few patients at a time.
Excellent. You've treated over 80,000 patients. What's the moment that changed you the most as a doctor?
Yeah, it's actually over 100,000. At some point it was 80, but there was no point, but there was an evolution. There was never a point. And one of my, I can say, I'm in my 50s, and the last 8 years, I've had tremendous growth as an individual and a person. And I've no shame to tell you this, that growth I'm going to call maturity, maturing into an adult in areas that I was a 12-year-old idiot, right? A lot of people look to me they think I am the one that saves them, knows everything. No, what people don't know is that I got my issues. I got my problems. I have my demons. I have my shadows. I have my shortcomings, right? Some personal struggles I've had in my life in the last exactly 7 years and 2 weeks. And
that's okay. Feel your feels, Dr. B.
Yeah, a personal responsibility that I had for a family member that I had to mature up in a lot of ways and grow up. And I had to really immerse myself also in clinical, theoretical study of the mind in some ways. Through that road, I have had to give in and grow, mature, understand a meditative process. And at times I've had to be Buddha, Christ, and Muhammad at the same time and shut my mouth and move forward and accept the situation with grace and look at it in the long term. In that road, I grew as a clinician in my understanding, empathy, patience. And that just contributed to everything else I knew. And it's been a process. And that's my answer.
One last question. If you could change one thing about the way this country treats addiction, what would it be?
I think the paradigm needs to be made. I think people need to understand that it is a clinical paradigm that could use real expertise. And I do wish the value of professional treatment, medical treatment, was more appreciated and accepted. And I see that sometimes with online stuff. For example, recently I put something online. That's where I'm thinking right now. But I'll put something online. I'm a big advocate of pharmaceutical grade heroin in the time of fentanyl, right? Mm-hmm. So I said, I said something to the effect that, there's a lot of people that I can actually titrate down on heroin over 2 to 3 years and they can walk off and live their life. And pharmaceutical grade heroin in a clinical setting. And, people have no problem just responding, giving me their opinion, it's saying, wow, you are a moron or something like that, like that. And it's bizarre to me. I wouldn't even have the courage to say something like that. Let's say a guy's a theoretical physicist and says something, I don't know enough about that field to make comments like that. What I do know is to some extent of my experience, and your experience is not a different view than the clinician who's treating you. I was very good at resuscitations, right? I don't have to go through having a heart attack and dying to be good at resuscitating you when you're dead. And they would say that, you have no idea what you're talking about. Man, give me that heroin. I'm going to go off the deep end. Well, you moron. I'm a clinician on here. I'm not giving you my emotions, feelings, beliefs, judgments, attitudes. I'm telling you something, and I've always said what I put on there is driven by data and clinical experience. And I think a lot of that is from a lack of respect for the ability to be able to approach substance abuse in a very clinical, formal way and treat it. And the other thing I wish I could change is that the institutional systems we have for treatment are still garbage, and we don't really have access. People don't have access, and when people do have money, oftentimes they're, eating gourmet food and petting a $1 million horse at a rehab is not treatment. And those with money go there, and those with the poor go to some other crap place. And I wish that could change.
I like that. Makes a lot of sense to me. Good. All right. Thank you for coming on.
Thank you. That was so much fun.
A lot of fun. How can people find you as far as social media? What are your handles?
Yeah. I think it's Dr. B 360. It's on YouTube, on the other ones. Facebook, same thing. Shorts, TikTok, Instagram. It's all out there. I'm on LinkedIn. I have a medical clinic in Orange County, California, that's strictly related to polypharmacy, substance abuse. Zephyr Medical Group. The website's being redone, but it's out there. And I think there's a avenue for those that are far away or aren't going to go to clinic to do coaching calls with me. And it's in the social media platform somewhere to reach out to me in that way.
Always a pleasure to have you.
Likewise, that was
Appreciate it.
awesome.
No, it was great.
Loved it.
And we're going to have to do
We got to do more.
of these.
We got to do more. And
We've got a lot to talk about. It's
Yeah.
gonna be too much to just...
yeah, you ask big questions with so much stuff. I'm like, dude, how am I going to answer that?
You did great.
He's asking like 6 questions in one, and he's asking all the right ones, but we need time. But
Most definitely.
we'll get
Well,
to
we
it.
have a lot of time. We're supposed to stay alive another 50.
I know, right? We'll see.
Thank you for coming on.
Thank you.
Another great episode. It was good to get with Dr. B today and talk to him about all the stuff that I've had on the forefront of my mind, all the different things that I'm seeing out in the field when I'm working and doing interventions, and a lot of questions that I have. I mean, I love speaking with him because he's not just a wealth of knowledge, but the man, he's got a good stance. You know, I do believe that we are like-minded in the sense that he respects what I do in the line of work that I do, and he keeps an open mind. He's not critical of me, and I'm not critical of him. You know, I know what kind of work he's done. I've seen a lot of different people that have gone through his clinic that have been success stories. And who better than to bring on an addictionologist, considering the fact that I work in addiction treatment quite often, helping people with addictive problems, alcoholism, mental health, the whole gamut. Great conversations. I always like to bring him on. I think that there's just too much to try to cover in such a short amount of time. Think about having him in some future episodes too, for sure, most definitely. If you like this channel, please subscribe. Please share everywhere. We would love to hear from you in the comment section. And until we meet again, Primary Purpose with Pej, my name is Pej.